And welcome, everyone. Appreciate your signing up. And there's an endless number of topics I could have picked to talk about because our spines are part of our everyday life. But today we're going to start with one of the most common things, which is talking about the discs that we have in our neck and our back, what can happen to them, how we take care of them, how we treat them, and what to expect from them if we do the right things. So without further ado, we'll get started. The discs are the cushions that sit between the vertebrae, which are the bones of our spine. They have a very thick lining, like a radial tire that goes around the outside of the disc. We call that the annulus. The inner part of the disc, especially when we're young, is quite a good cushion, and we call that the nucleus pulposus. We'll just call that the cushion today. And you can see on this diagram on the right how the disc in cross-section has these thick outer rings. That's the annulus, the cushion part in the middle, and how they're situated between each of the bones of the spine. If we do a look at this diagram that I'm pointing at, you can see where the openings for the nerves are that come off the spinal cord and come out of the spine and go down to your legs. And we'll be talking about how those nerves can be affected by the discs. So discs can do a lot of things. You can tear that lining. If you read a radiology report, you might see the term annular tear. Most of us get those as we get older, so they're pretty much a normal finding over the age of about 40. We don't get too worried about annular tears. But if the tear gets large enough, some of that cushion, the nucleus pulposus, can squeeze into that tear. If it just pushes that torn portion out, we call that a protrusion. If a piece comes completely through that tear, we call that an extrusion. But both of those are herniated discs. Other people call them ruptured discs, slip discs. All those terms mean the same thing. It just means that part of the disc is not where it belongs and is starting to cause trouble. If you have other conditions that harm the disc over time, the disc can also degenerate, meaning it's less of a cushion. It dries out. If it gets really dried out, it can actually collapse down to where it's almost bone on bone. Those conditions are accelerated if you're a smoker or if you're obese. If you're heavy, the discs wear out quicker. And smoking definitely increases the wear and tear on the disc because the disc doesn't get as much nutrition if you're a smoker. And then, of course, as we get older, almost all of us get shorter. Our grandparents were shorter than they were when they were parents. And that's because the discs primarily get less tall. As they have less cushion and they age, they start to shrink. And that's a normal part of aging for most everyone. So here's a few MRI scans that show the differences. These are all MRI scans from a side view of the spine. So we're facing to the left. And if you looked at the farthest left one, a normal disc is here, where it has a thick lining in the front and the back. And this ribbon that I'm pointing to is where the nerves run down the center of the spine. And you can see how these two discs both have herniations. That lining has torn, and this material has protruded out. So that would be a disc protrusion. And on this one, the lining is torn, and this piece of disc has come all the way out through that tear, and that would be an extrusion. So those are both two different ways that a disc can herniate up against the nerve. The central MRI shows a disc that's not herniated, but degenerated. So again, here's three normal discs above it, sharp linings, nice tall cushion. And you see the lowest disc here, which has lost most of its cushion. It's narrow, top to bottom, and there's some swelling in the bone marrow on either side, which means this is a painful, degenerated or collapsed disc. This can happen from trauma. This can happen from a herniated disc that healed on its own, but the disc just didn't behave over the years. And it can cause a fair amount of low back pain if you're a young person where this is bone on bone. And then on the far right, I have an MRI about how we age. You can see here there's 3 of the 5 discs that have gotten shorter. So this patient's a little shorter than they used to be. These 2 discs in the middle have been pretty well preserved, but none of them are causing any trouble on this ribbon of nerves that are running down the center. So this would cause mostly either no pain at all or a little bit of stiffness in the back as that person got older. So here's a diagram that shows what a herniated disc looks like. Again, that lining of the annulus is torn. The material in the center can push through that tear. And if it does, it can pinch that nerve that's trying to get out of the nerve tunnel from the spine. And these can go in all different directions. The most common one is seen here, where you get one-sided sciatica, or pain that goes down your buttock and down your leg from that nerve being pinched. You'll hear the term bulging. Bulging discs are normal. We all have them. They're part of the daily routine. If you were to MRI your back in the morning and MRI it again in the evening, you'd have bulging discs in the evening that weren't there in the morning. It's just from us being upright all day. So if you see that on an MRI report, it's nothing to worry about. A bulging disc is a normal finding in all of us. Herniated discs are different, and those can be either, as I show here, protruded, extruded, or even traveling in the spine, which is called a sequestered disc herniation. That means it went up or down and is probably not going to get back where it belongs no matter what we do. So here's what an MRI scan looks like of a herniated disc. This is a cross-sectional view now. So if you were to see the patient, they'd be lying on the skin would be at the bottom here, they're lying down. Here's a nerve going to the left leg, which is fine, but you can see the nerve going to the right leg is being squished by this large lump of disc material that pushed backward from the spine into the nerve root. This is an MRI as a perfect way to diagnose a herniated disc. Rarely you can also see it on a CAT scan. Nobody does myelograms anymore, and they really are not needed for any patient anymore. So who herniates a disc? Well, anybody can. They're most common when we're younger. I would say age 25 to 50 are the most common years you can herniate a disc. I see more now in adolescents because some of our sport coaches are pushing young kids a little too hard with weightlifting. And then you can actually herniate your disc even in your teenage years. And in some of our older patients who have stayed physically active and healthy, they can have spines that act like a younger person. So we do occasionally see herniated discs in people in their 70s and 80s. They're definitely most common in active people, such as athletes who are really stressing their discs. Lifting improperly, like bent over awkwardly, and lifting something heavy is a very common way to tear the disc and then eventually herniate it. We do see it in heavy laborers who are doing a lot of that type of lifting and simply wearing the lining of the disc out. As I mentioned earlier, smoking decreases the blood supply to the disc, and so smokers have a 3 times higher chance of herniating a disc than non-smokers. And if you're heavy, you put more stress on the discs on a daily basis, and that can also lead to more annular tears and eventually disc herniations. So often herniated discs are a 2-step process. So often the first injury or lifting causes a tear in the annulus, and your back hurts. It hurts a lot, usually right over your hip bones. And it may be a day or 2 later where you're coughing or sneezing or just twisting, and suddenly now you get sciatica because you started with a tear and then something you did then pushed some of that soft nucleus pulposus material through the tear. And so often, if you really listen to your back, it's a 2-step problem if you herniate a disc. It starts with back pain, and a day or 2 later, leg pain. And the term sciatica just means that you've got pain that radiates through your buttock, the back of your leg, and sometimes all the way down to your heel or to your foot. And they're painful. They're really painful. I've had one myself. It's hard to ignore a pinched nerve pain, partly because there's pressure on the nerve, but also the disc material itself is very inflammatory, and it really stirs the nerve up quite a bit. So that first week or so with a herniated disc, it's really painful, and it's something you want to take care of right away. We don't jump right in and do something, but they're really painful right away. As I mentioned, they're usually activity related. They start with back and buttock pain, especially if it's in one of the 2 lower discs. If it's one of the higher discs in the lumbar spine, you can actually have thigh pain from the front of the leg, and it can be confused with knee pain too, but most frequently it's one of the two lower discs. You can get tingling in one of the toes or around the calf. You can get weakness, and if it's a really large disc herniation, you can actually get a drop foot or feel weak in that leg right off the bat. That makes it more urgent to get treatment if you have weakness right away. In general, if you've truly herniated a disc, it's hard to sit, it's hard to bend forward, and it's hard to valsalva or put pressure like you're holding your breath hard, because that increased pressure puts more pressure on the nerve. Coughing and sneezing, which is a part of a valsalva maneuver, can really make pain worse if you have a herniated disc. So what happens with a herniated disc? Well, if they're just bulges, like I said before, those are normal findings. We ignore those. If you have a protruded disc, believe it or not, 70 to 80% of the time, they will get better in the first 6 to 10 weeks. If it's an extruded disc, that's only 50%, because sometimes that piece of disc can actually be resorbed by your body. So in general, we try not to do surgery or any treatment immediately. We try to let it follow its natural course and get better on its own, which works more than half of the time, as long as you don't re-injure it. If you start with weakness, often that will improve if we're just careful in those first 6 weeks. Half the time it will get better. So what works when it's really painful to begin with? Well, an anti-inflammatory like ibuprofen or Aleve is helpful, because as I mentioned, the disc is really an inflammatory material and the nerve is very much inflamed. If you go to an emergency room or urgent care center, they'll often give you some opioid or narcotics for this sciatica pain, but that won't be very effective. For some reason, narcotics are not that effective for nerve pain. They are effective for muscular pains and other things, or if you've had surgery or break a bone. But you can take a lot of narcotics and they still won't calm the nerve pain down, which can get some patients in trouble. What does work best is if you combine an NSAID like Aleve with Tylenol and with a drug called gabapentin, which is a very specific pain medicine for nerve pain. And that combination of those three is often as effective or more effective than a true pain pill. Some primary care doctors will just prescribe a Medrol dose pack, which is a steroid pill that you take for 6 days. And that can also be helpful calming that acute inflammation of the nerve down. So early on, all of those things can be helpful. What's not helpful? Strict bed rest, which was popular 20, 30 years ago, actually gets you weaker in your nerves and blood flow. And I would not recommend yourself going to strict bed rest. If you can tolerate it, some type of aerobic activity is okay, like a stationary bike or an elliptical trainer, because that increased blood flow you get from getting your heart rate up can help the nerve feel better and help resorb the disc herniation. If it's too painful to do that, then of course you can't do that. The key is to not make the disc worse. So when you first get a disc herniation, you want to avoid any forward bending or lifting in that position. Avoid heavy straining if you can. Try to stay upright with your back in a good posture. And there's one exercise you can do in physical therapy that's really geared towards moving that herniated piece back where it belongs. And that's called a Mackenzie's press up. If those of you who've been in physical therapy know, it's sort of like the cobra pose in yoga. So you're doing a push-up, but only pushing up with your arms and letting your back sag onto the floor. So you're getting sort of a passive hyperextension. And that positioning is trying to move that herniated bulge back where it belongs in the spine. Other things have not been proven as helpful as I'll go through, but the Mackenzie exercises in physical therapy is a helpful start when you first have a disc herniation. As I mentioned, 70% or so of these will get better if you can make it to 6 or 8 week point. We do start physical therapy immediately because that's the most helpful way to get the treatment started. We'll consider a discectomy if you get no pain relief by that 6 to 8 week point and it's really disrupted your life. If we do surgery, it's called a microdiscectomy. So again, we reserve that for patients who haven't improved in those first 6 to 8 weeks or who have weakness. It's a small incision, usually 1.5 inches. I work under a microscope, so it's magnified. We put in a special little retractor to spread the muscles a little bit, and I only take out the pieces of disc that are causing the trouble. Try to take out enough disc so the lining of the disc can come back together, and then we have to let that heal for a few weeks after surgery. So you are going slow for a few weeks after surgery, but you're walking around and driving right away. It's outpatient surgery. Most patients go home within a couple hours, go back to work within a week, unless it's really heavy labor, and then they have to wait 4 to 6 weeks. Usually 4 weeks after surgery, I can start some activities back, some exercises, and get people back to normal activities. When do we do surgery? As I mentioned, if you have intractable pain that goes on for more than 6 to 8 weeks, if your nerve is just not working well and you begin to get weakness, that will prompt us to do some surgery earlier. And very rarely, if the disc herniation is really large and starts to affect your bowel or bladder control, that's more of an emergency situation, and we'll do that surgery immediately. There's been a few studies that have compared surgical treatment of herniated discs to non-surgical treatment. Those are called randomized controlled trials, RCTs. The very first one was done in 1983. And for all of these trials, they usually wait 4 to 6 weeks first to see if you get better. And if you don't get better, then they were randomized to either no surgery or surgery. And in all three of these trials, which are the three best ones that are out there, patients did better with surgery than without surgery. They do better at 6 months in the first trial from 1983. In the second one in 1999, they compared injection to microdiscectomy. Patients did much better with a microdiscectomy. And the last one was done in Scandinavia, where they followed patients for 10 years, and the surgical patients do better at every time point, 1 year, 5 years, and 10 years. And that's comparing it to continued physical therapy. So again, I want to repeat that all of these trials are on patients who didn't get better in the first 6 weeks, and they were randomized to either surgery or no surgery. So nobody wants back surgery, nobody wants disc surgery. But if you need it and you're still hurting at 6 weeks, you're actually better off in the long term to have that pressure off of your nerve than just to tough it out and see if it gets better over time. What doesn't work? Well, chiropractic adjustment can help if you have a muscle strain or some mechanical back pain only. It's not been proven to help with a herniated disc. And in fact, if it's an aggressive manipulation, can actually herniate more disc. We do use injections on occasion, and it's usually in those first 2 weeks of a disc herniation where you're so painful that you're having trouble even moving and getting out of bed or getting to work. And then we'll do an injection around the nerve with steroids just to calm the nerve down to see if you can get to that 6-week point. Injections don't change the herniated disc. They don't melt it away. They don't do anything magical. They're just buying time. If it's more of a chronic herniation and it's been there already for 3 or 4 months, there's no point in an injection. It's not going to change anything. You'll see a lot of advertisements in the newspaper or online for things like special mechanical tables, inversion tables, hanging upside down, using lasers, using special suction devices, a rhizotomy or radio frequency ablation. None of those things will work for herniated disc. There's no data present that any of those make a difference. Traction doesn't help. But they've all been tried, they've been studied, and scientifically, there's no evidence that any of them make a difference. So just in summary, a lumbar or low back herniation is very common. Many get better on their own, but when they don't, the microdiscectomy is a very successful, low complication way to get yourself better. Just briefly, I'm going to talk about your neck too, because we have discs in our neck and the cervical spine that can do the same thing. They can herniate, they can degenerate, and they can age. There's a few differences. So this is an MRI from many years ago, a side view again, that shows a herniated cervical disc. But this time it can actually cause pressure on your spinal cord. We don't have a spinal cord in our lower back, just a ribbon of nerves, which are a little more resilient. spinal cord pressure is not very resilient. So some of these patients that herniate discs in the neck can't wait very long and get surgery sooner. They also have a lower chance of getting better on their own, probably 50% versus 70%. And again, if there's weakness or findings of spinal cord pressure, we might do surgery sooner for a cervical disc herniation. What are the symptoms of that? Similar to your low back, it would be neck pain that radiates into your arm. So a classic herniated disc in the neck will cause pain that goes into the shoulder, across the forearm. It might make your hand have numb spots or tingly spots. You might get weak in your biceps or triceps, depending on which disc is herniated. You may also get spinal cord symptoms, which are unusual, but often hard to ignore. There are clumsiness in your hands. You can get really loss of balance and a weakness in how you walk and stagger a little bit. Those are more of an emergency if we get some of those symptoms. And again, you can get some deformity where the disc begins to collapse, like this patient who had a chronic disc herniation, and you can see on the x-ray that that lowest disc you can see is quite narrow now. There's almost no space left. We're beginning to grow bone spurs around the front and back of the disc. And that can just become more of a neck pain chronic issue, which we have solutions for as well. And then finally, given enough time, you can get multiple discs that begin degenerating. This can be a normal part of aging. It can also happen earlier in life, which can cause us to lose our normal sort of sway back curve to our neck and also create some chronic neck issues. So what can we do if things don't get better? Well, we can do surgery for a herniated disc in the neck. The difference is we don't usually go from the back of the neck, we go from the front. If you remember that MRI showed that the spinal cord would be in the way if we tried to get to the herniation from the back of the neck. So most commonly we go from the front to avoid having to move the spinal cord. And in this case, then to get to the herniated disc, we have to remove the entire disc. So I make a small 2-inch incision in one of the creases in your neck. We go in from the front of the neck and take the whole disc out, take the herniated piece out under a microscope so I can be sure the spinal cord has got no pressure on it anymore. And since we had to take the whole disc out to get to the herniation, we then have to replace it with something. And these days, I most commonly put an artificial disc back in, which is a titanium ceramic ball and socket, lets your neck move. You don't have to wait for anything, you don't have to wait for anything to heal. And you get back to normal activities very quickly with a disc arthroplasty or artificial disc. If the disc has been chronic and completely narrowed and collapsed and bone on bone, sometimes we still do fusions to replace this instead of an artificial disc. Less common than it used to be, though. So just to summarize the talk, and we'll have some time for questions. Our discs can do a lot of things. They all age. They can herniate and pinch a nerve. That's a common problem in young active people. Many of them will resolve early on. But if you have sciatica or arm or leg pain for more than a week with back pain, you probably should get an MRI to make a diagnosis. That'll allow the physical therapist to start the proper kind of therapy with you to see if you can get that to resolve on its own. If it doesn't resolve on its own, it's not the end of the world. Microdiscectomy is very successful. Many pro athletes have had microdiscectomies and gone back to being professional athletes, so it doesn't preclude you from complete return to function. It's usually a recovery between 1 and 3 months to get back to absolutely full activity. Having discs narrow with age is something hard to avoid. Certainly by not smoking and watching your weight, you can slow that down. But sometimes it's just genetic programming that leads to that, and you really can't change it. So I hope this information's been helpful. We have time now for me to go through any questions that you may have and talk about things that maybe I brought up that aren't quite clear. Thank you so much for your attention.